Well, I think we'll get started. If it's all right with everyone on the panel. I'm delighted to welcome you. I'm Gail Rousseau, professor of neurosurgery at the here at George Washington University, and along with my co-founder of the GCCA, Kate Douglas of the Department, Dr. Kate Douglas of the Department of Emergency Medicine, we'd like to welcome you once again to a webinar sponsored by the George Washington University School of Medicine Global Clinical Care Alliance, the GCCA. We are delighted to have this initiative of the School of Medicine be part of what is available to all of our campus, and particularly to medical students, residents, faculty, and staff of the School of Medicine. We have some exciting things to share with you today. The first are just a couple of announcements. First of all is to remind you of the existence of the GCCA. We're a big, broad tent. We welcome anyone and everyone at GW who, or beyond, who is interested in partnering to help in bringing access to quality care, healthcare to people everywhere who are in need of it. The other thing is, in these days of sometimes having not so much good news, when we tune in to news programs, we have some very good news to share, and that is that the GW School of Medicine has been endowed with funds that will provide for a global health fellowship that will be available starting this academic year. Applications are being accepted now for the coming year for residents at GW who want to do a year-long project in global health. It's a very generous fellowship, and it is not through NIH, USAID, or any government source that can be threatened. It's through a private donation. So all GW residents will be getting information about it in the coming 7 to 10 days, as will every program director and every department chairman. So we're very happy to be able to share this good news with you and this excellent brand new resource, and we hope that you'll take advantage of that. And so with those introductory announcements, I'd like to turn it over to my good friend and colleague, Dr. Kate Douglas, to introduce the panelists today. Dr.
Yeah,
Douglas.
thank you, Gail, and good afternoon, everybody. I do see people popping in to the meeting, so thanks to everybody for joining, and thanks so much, Gail, for bringing us some positive news. Again, that's a really exciting opportunity that we're going to be sharing in the coming days to weeks, and we look forward to launching this really excellent opportunity to build the work in global health and build the opportunities for the GW community to really make an incredible impact. Today, speaking of impact, we are really happy to have Dr. Berndt Schmit and his team here to present their work as part of our webinar series from the Global Clinical Care Alliance. Berndt is a passionate leader in global health. He's a radiologist and also the president of the Humanitarian Radiology Development Corps, which is a foundation that's spearheading efforts to bring sustainable improvements to healthcare infrastructure in low-income countries. So as a radiologist, he deploys radiology equipment and also works to build self-sustaining healthcare services in many countries around the world. And he has brought together a great team of folks who are going to share their experiences. And I am really looking forward to hearing this presentation and learning more. So I'm going to turn it over to you, Berndt. In the meantime, anybody who has a question, please feel free to put it into the chat. We will have some time for Q&A at the end of the presentation, and also try to bring up questions that are relevant in real time as we go along. But with no further ado, over to you, Berndt. Thank you.
Awesome. Thank you, Dr. Rousseau, Dr. Douglas. My name is Berndt Schmit. I'm real excited to talk to you today about our organization and our experiences doing radiology capacity development in low-income countries. So I've got a bit of a quick tour of everything we do. Disclosure, so I'm actually founder of Humanitarian Radiology Development Corps, and I put our little webpage here. So if you want to make a donation, you can do that. That's tax deductible. And I'm going to declare that's not a financial conflict because it's for a charitable cause. I also do some advising, which is not relevant to this talk. And let's see. So we'll talk about hardcore concepts and our approach, some of the things we do. And then I've had a number of people approach me over the years asking how I got into global health and my path in global health. So I'm going to give just one slide about my personal journey in global health and some of the things I've learned personally from that. Then we'll talk quite a bit about projects. So that's going in the field. That's my happy place. And then we'll end with voices from the field. So I got two of my team members, Komlan and Yamile are both on already. Emily, I think, is on a flight. I don't think she's gonna make it today, but we'll try to make do without her. She's awesome. And so, humanitarian radiology development core, that's too long to say. So we always go by our initials and we call ourselves hardcore. It makes us smile because we have a warped sense of humor. I hope you get that. Capacity development is something, that term is sometimes new to folks, but I think by the end of these 20-something slides, you'll probably have a better understanding what we mean by capacity development. So we're building services and the whole enchilada of things that make a sustainable radiology practice or clinical service. So that may mean assessment, that may mean the education components, that means finding equipment, donating equipment, getting it through customs delivery, all the logistics involved with implementation and long-term part support, maintenance support. So we're a 501c3 charity organization in the United States. If you're from outside the United States, what that means is you can make a donation and you can actually get a tax deduction in the United States for your donation of either equipment or money. Most of our work used to be in Haiti, probably 90% was there, and now just by happenstance and some of the just terrible destabilization that's happened in Haiti, most of our work now is in Togo. And like I said a second ago, there's three main things that we do. Assessment stuff, which is assessment of facilities, the personnel skill sets, as well as education, all the different components at different learner levels, and then everything that's involved with equipment. And here is, I'm calling it a dashboard, but really you have to forgive me. I'm going to brag a little bit or try to brag. So to date, we've donated, it's almost 50 ultrasound machines in a bunch of different locations, also 3 computer PACS systems, some X-ray equipment. We did one mobile breast cancer screening truck that was in Bolivia. We teach at a bunch of different levels. And we've got some organizational outreach. We're now working very closely with another American charity called Curing Women's Cancer. We help in the foundation of a society in Haiti. Here's just some grab shots of this is the kind of equipment that we donate, and away we go. So this is the one slide. I'm a little sheepish about talking my own personal journey in this, but again, it's come a lot from, let's say, medical students and residents. So I actually started as an emergency medicine resident, and part of why I chose that was for the global health angle. So no question, emergency medicine is a great skill set out there in the field. I knew I wanted to be a hands-on person with my global health work. I'll call it the lifestyle emergency medicine, being shift work. It's amenable to a big travel footprint. So early on in life, I said, wow, this is something I want to do for the rest of my life. And it was all a brilliant idea until the part that I burned out with emergency medicine and ended up switching into diagnostic radiology. As a radiologist, I figured, oh, I'm not going to be useful in the global health arena. We're too, far removed from the field. That just won't make much of a difference. And it turns out that's, I think, wildly incorrect. There's a massive need for radiology in low and middle income countries. And what I've seen is radiology is a real gateway technology. It's a potentiator for other clinical services. So you have a given hospital that maybe has surgery, has functioning ORs, you add imaging, and everything can now provide a higher level of service. So if there's one message to give everybody, it's if you're interested in radiology and global health, there's just massive need for work in imaging. So I stumbled on a different charity organization that was mostly teaching focus, and I kind of woke up with this epiphany while I was lecturing the Haitian radiology residents, teaching them about MRI. And I had this epiphany that was frankly kind of an awful gut punch of realization that I'm teaching MRI to people who don't have access to MR imaging. There's very little, well, we think there's one MR machine in Haiti that's working. And so this became a bit of our mantra and the foundation of hardcore. We're teaching people to fish who don't have fishing poles, and that disingenuous realization that unless we're also providing all the other components, the teaching really isn't something that can come to any kind of fruition. So we started hardcore, and I think with that came a number of other things for me, just on a personal level. Of when I started out, no question, I had a very idealistic idea about what global health was going to be. And as an emergency medicine doctor, I was going to personally save every single starving child on planet Earth. And of course, that doesn't really work. And so there was a shift when we started hardcore into a service model. We're here to serve, not to succeed, not to achieve an outcome, not to achieve a certain metric. And untethering our work from those outcomes meant we could be much more flexible. So personally, I had to build some boundaries. I became, I think, a more flexible, adaptable person. But this also allowed us to better tailor our work to what the client actually needs. Other things, well, I think I've always had a wacky sense of humor that is no question really useful in the field. Our work can be very difficult with lots of obstructions, a lot of failure points, and so the resilience and humor, I think, really helps us stay sustainably in the field doing this work. And of course, there's this journey of humility, starting out wanting to save the world, realizing maybe you can't, and how do you stay in the game as someone who's actually helping and making an impact. So back to hardcore, we're a self-funded charity, and to put a real clear understanding of what that means, it's personal resources, so that's time and money that we're putting into this organization to do our projects. And what this also means is we're not externally dependent on outside resources. So if we make an engagement, yeah, that's a personal engagement, and there's a personal fulfillment that can come from that. But also we're removing some of the externalities that may put the project at risk because you're waiting for funding or approvals and that kind of thing. All right, so back to sort of hardcore and bigger picture. Our approach, I've been calling it precision charity for a couple of years now, and we always begin with an invitation. So that's critical because the invitation comes from somebody from that culture, from that country, and they help us navigate things like the language, the regulatory environment, the government, cultural issues, all of that. So always start with an invitation. We're very client focused, like I alluded to a moment ago, and just to expand on that one other dimension, we're not agenda focused. So as larger organizations, I think many of them, they maybe because they have to, they do things like they create a 5-year plan to address, let's say, maternal health. And that's great, but let's say your client is a pediatric service or something. They then try to make their program look like it's maternal health oriented for 5 years. And then when the agenda changes to maybe infectious diseases again, now the client has to whiplash to making their pediatric program look like it's TB and HIV focused. So I've personally seen that out in the field, clients scrambling to try to get funding from outside sources. We try to be very different about that. Once we're invited, once we're working one-on-one with a client, we address what their needs are, and we don't bring our secondary kind of agenda into the picture. So practicing precision charity, I think some of the reasons this works so well is we put senior experienced clinicians into the field. And that means right from the get-go, we have a better idea of what's actually happening. So our assessments are, I hope, more accurate. And we can do real-time decision-making. So literally, we may meet an obstetrician in a hallway, have a conversation. We already know the hospital maybe a little bit. We get a sense of what they need, what we can provide. And by the end of that hallway, we've already committed to a project and when we're coming back. So we can telescope because of our size and putting that senior experienced people in the field. We can remove some of these steps that other organizations have to do with reporting and proposal making and approval processes. And so we hope from a client standpoint, what we do is very nimble and responsive to what their actual needs are. And of course, those needs constantly change and the context changes and we can be responsive to that. And perhaps goes without saying, every project is custom tailored. All right. That's enough sort of the philosophical thing. So let's jump into some of the work we actually do. And I'm going to give you some pictures and I'll ask some questions and we'll try to make Zoom interactive, which of course it really isn't so interactive, but we'll pretend that we are. Okay, so here's some pictures. We're in a very small, very rural, about 3 hours outside of the capital in Togo. And this is Harriet. She's a midwife. And I want you to just look at this bottom left picture here. And what do you see that's missing? So I'm going to ask you to be a radiologist. You're going to look at an image, you got to be thinking, and I'm going to be talking to you at the same time. I want you to process all this from the context of where we've been asked to provide her ultrasound donations and training because she doesn't have, their patients don't have any access to ultrasound. And so what's missing? Well, we look at this, there's no soap. So do they have, are they able to support a consumable budget? And how about is there hot water? Well, if there's a single faucet, it's probably just cold water. And of course, we could ask that, but just we're going to exercise some assessment, visual assessment kind of skills. And so if we're going to make a donation of ultrasound, how are we going to clean the probes? That's where that is going. All right, here's another one. So now we're at we're in a pediatric department. There's probably 5 wards. This is the main university hospital in the capital city of Togo. And here's just a picture. This is the babies, I think, 0 to 12 months of age. I have other pictures I'm not going to show you, but each bassinet has 4 babies in it. And what's missing here? Pretend that you guys are answering and I'm seeing raised hands, but we'll forge ahead with Zoom Interactive. So what's missing is there was 0 equipment in this room. So behind these this IV stuff, there was one nurse. There was a scale there, but otherwise this room had no pulse oximeters, no cardiac monitors, no EKG machines, no IVACs. The mom sitting right here is the one giving the tube feeds. There was the one nurse in the room. And I show this not to generate, I don't know, pity or something like that, but rather to understand we're now stepping into this setting, have been asked by the pediatric chief to donate ultrasound and provide training. And this is the context of how ultrasound would be impactful. So just to walk that through, maybe you don't have a pulse oximeter, but now you can do an ultrasound looking for effusion and looking for lung consolidations, and maybe that's a different way to answer the question. Okay, different hospital, also in Lomé. This is a district-sized hospital. It does OB. And I'm just showing you 2 pictures from the lab and one from, they did have a pretty nice ultrasound machine. I'm going to ask, what can you learn from looking at this, or what did we learn? So again, I'm a radiologist doing capacity development, and look around. So first of all, the windows are closed. It's actually cold in this room. The air conditioning is working. Why is that important? I'll let you think about that. We actually have hot and cold water. We got a soap dispenser. I don't know if the soap dispenser is full, but it implies that maybe we can handle supporting consumables. They're actually using gloves. That means they can access gloves. And what are these 2 black boxes here? Yeah, the uninterruptible power supplies. And what does that tell me about the electrical stability at this facility? Well, it tells me actually 2 things. So first of all, you probably want some kind of UPS to protect your equipment. So that's both a battery and the circuitry that stabilizes the voltage. So the battery provides enough electricity so you can shut down the machine safely and save your images. And the circuitry stabilizes the voltage so it doesn't damage circuitry with the brownouts. So it tells me, first of all, I'm going to have to supply UPSs because they're doing that, and that's the level of the electric power grid. But also it tells me this facility is able to purchase them, support having them. So it tells me how healthy is this hospital at providing consumables and equipment and supporting the functionality of that. So again, context of I'm going to add capacity. Am I burdening them, or are they already capable of maybe supporting another piece of equipment? All right. You guys are now experts at doing assessments, at least the visual equipment part of things. Of course, there's all the other assessment stuff that happens with working with the people to sort out what is the skill set, how well do we work together, and that kind of thing. All right, education. You guys probably know a lot about education, but I'll try to give you some kind of pearls and some little other concepts to think about with this. So we do some lecturing, but that's not actually our main focus in the capacity development arena. So why do I actually give lectures? And here's the question. You can get a great webinar online and a recording and play me back at 1.5x, and maybe even find a lecture in good French, not my bad French. Why do I fly somebody all the way across the ocean to give a lecture? So this is actually, in my opinion, what we're really doing is relationship building. These folks can get their education in other ways, but what I can really do here is relationship building. So these are the future radiologists that are going to be in Togo. Walk this through with me. I'm going to add some, let's say, ultrasound or X-ray capacity at another facility. Who's going to be the future radiologist that's going to work with that equipment? So I'm looking for the superstars here that are going to eventually be in private practice to put food on their table, but still work in the public sector that we're doing donations in. And then they are going to be willing to work in the public sector at a very, very discounted wage to help the other people in their country. So this is me relationship building. This is me letting them get to know who we are, that we come back over and over again, that we actually get things done. And that's the real, in my opinion, the real impact of our lectures. All right, this is a seminar that Natasha used to run. This is back in Haiti, and these were just super popular. The pearl here is after we gave 3 annual ones of these, and by the 3rd one, some of the students kept coming back, and the natural leaders formed what then became the first ever Haitian Technology Society. So we don't take credit for that, but I think emphasizes when you are really empowering people with your education, with the capacity development that you're building, I think other things start to happen. Empowered people start to have hope, they start to see their own way forward, and they create their own organizations. So I think this is super exciting when you see independence growing from the empowerment that maybe you're helping them find. And then the hands-on ultrasound training, my gosh, I would say this is 90% of what we're doing when we're in the field. It's not the lecturing, it's not the assessment, it is this. So here's Luana, she's bending over somebody, and just some nice tidbits. If you have a volunteer or a patient or something you're scanning, it's back-breaking work because you're leaning over, holding your student's hand, guiding them, tracking a kidney or whatever you're doing. This is Dr. Hirschman, and this is another way to do things. The person who's teaching is now actually the volunteer being scanned, and this is a much better way to do things. It's easy for me as a teacher when I'm laying on the bed. I can see the monitor and what they're scanning. I can reach the buttons. I can hold their hand. I can tell how hard they're pushing or not pushing. I can see their faces and see what they're struggling with. So this is the way you want to do things. So secret little advice: wear a bathing suit. You go. You're the volunteer. When you come back to the hotel, you're covered in a lot of dry ultrasound gel. Good stuff. Okay, so we're going to go over 4 capacity development projects, just kind of quick, and give you a feel for different examples of what we've done in the field. So 2 of these are from Togo and 2 are from Haiti. So this is our midwife project, and that midwife with the red dress, the first assessment spot, her name is Harriet. She's the one that said 50% of the patients that come to her in labor don't have ultrasound, and she's at a facility that has no ultrasound. So just let that sink in for a minute. 50% of your patients that you're going to deliver, you don't have ultrasound. So you don't know if it's breech, you don't know where the placenta is, you know how much fluid there is. And so she asked, can you donate some ultrasound equipment and teach me how to use it? And literally, after doing that tour you saw the pictures of, we went to this little outside bar. I think I had a beer, we had a little bit of lunch, and by the end of that, we made the decision in the field that this would be a project that we would do. So Harriet pulled together 5 other folks. These are all complete novices at ultrasound. We donated, I think it was 3 TE airs and 1 laptop ultrasound machine. And in 1 week, we taught them what we're calling the Big 5. Not sure what other people call them, but this is just these 5 basic things. And by the end of, I'd say Wednesday, they were getting pretty good at this. By the end of the five-day seminar, felt really solid that these midwives have gone from novice to be able to do the Big 5, and for their situation of being out in the middle of nowhere without obstetrical backup, no surgical backup, this is a real big step forward. So fun pearl from the field. Which of these 5 things was the hardest for them to learn? I was surprised. So I thought fetal position might be the hardest thing. They actually struggle with placental position. I still don't understand this. We talked about it quite a bit. I'm not sure why. We had to kind of create a model out of a backpack in the field to help them kind of understand the placenta, which is strange. These are midwives. They handle an actual placenta several times a day, and yet somehow conceptualizing where it is inside a mom when using ultrasound was difficult. So maybe that's an interesting academic project for somebody. This is a month later. This is one of our donated ultrasound machines from one of the midwives that we trained. And this is her showing the mom that her baby is in fact alive, because a patient came in, couldn't feel the heartbeat, couldn't hear the heartbeat. And so this for us was beautiful feedback that indeed our project worked, and we're making an impact. Let's keep going. So next project, so this is Dr. Jules. He's chief of pediatric at the University of Lomé. He asked us to engage and help them with ultrasound donation and some training. Their situation is that the hospital does have imaging. There's a CT scanner that's functioning as we understand now. They have ultrasound, they have x-ray, but it's in separate buildings, and the kids are too sick to go there. They don't have nurses that can try, go with them. There's no monitoring equipment like you saw a minute ago. So the idea is them having their own ultrasound was a game changer. Quick assessment, pretty clear what we needed to do. Dr. Jules actually was trained in France, so he already knew how to scan. These are the pediatric residents that we're training. And this is pictures of the first ever ultrasound guided biopsy done in pediatrics. Before this, biopsies were done blind. So like this is, I think it was about an 8-year-old girl who had an obvious mass in her abdomen. I think you'd be able to hit that pretty easily with a needle, but you could imagine if you get back negative tissue, you probably have a false negative, and how do you handle that when you're in a very difficult austere environment? So a fun pearl from the field, whoops, on this one. So we don't have sterile ultrasound gel. I mean, we do, but we just don't bring that. That's just logistically too much stuff to have filling our suitcases. So we learned this trick from them. They used sterile gauze. You unfold it to just a single sheet, and you put your sterile saline on that, and that works great as a ultrasound coupling gel equivalent. So I didn't think that was going to work great, but we did it, and it's just fine. So single layer of gauze, sterile saline on that works just fine. So learn that from them. Put that in your hat. Okay, this is now in Haiti. This is the Chancel Hospital. It's the main OB hospital in Port-au-Prince. So, gosh, city of probably 3, 4, 5 million, very poor people. It's a pretty austere looking hospital. They had ultrasound machines. They'd all been broken for years. So just let that sink in. You got a major OB hospital, no functioning ultrasound. Just kind of terrifying. So that again was one of those very quick assessments. You got OB docs who know how to scan. You got OB residents who are being taught how to scan in other facilities. And so we donated 3 machines. And oops. And here is the question for you. So we had them do a logbook, but what is a bad thing about asking our clients to do a logbook? And this gets in a little bit of the cultural humility things. So of course we want a logbook. We'd love to have some data and feedback. And sometimes when we engage a client, we say, hey, we're going to want some kind of data because our donors want to see that. Is the equipment being used? That kind of stuff. But where I sit in this whole process, I usually know the people that are receiving things. I'm not worried about them wasting the equipment or doing something, unintended or something. So the logbook gets tricky. In this setting, we did this because these are residents typically scanning. So there's multiple residents doing a exam. So there's one resident who could easily fill in a logbook, and that's fine. But I think what I'm trying to get at here for you is the idea that gathering data is burdensome. And is that burden something that's helping the client? Are they going to do some kind of study on this? Are they tracking data for their educational reasons or something? That's fine. Or are we gathering this data because I'm going to make a publication that's going to help my career? So we try to parse that out very carefully in our projects. What we're doing, if it's academic or not, or is this strictly charity work? And wow, I'm going to give you this present, and I'm not going to ask you to prove to me that you're using it correctly because, well, we have fundamental trust. Another pearl on this slide. So the M+1 rule we were doing in Haiti with the Sequoia donation. So these are all these big machines are Sequoia machines. They're refurbished. So if we assessed a hospital and said, well, you need 2 ultrasound machines, we donated an extra one. And the thought is if something broke on site, they could immediately deploy the spare machine, and there wouldn't be this down period of 1, 2, 3 months till we could get a bioengineer and find the parts and repair the thing. So it's our commitment to providing sustainability in a resilient way to each of our projects. Here's the fun question. The machine that breaks, is that junk? Should you throw it away and recycle it? Think about that for a second. Absolutely not. That broken machine is what we call a parts mule. So that's what we take parts from to fix other Sequoias in the country or at that facility. And we've actually done that a number of times. So broken equipment is actually gold. Do not throw it away. Don't recycle it. You keep that equipment on site because you just never know when you need the power pack out of this one or the hardboard or something. All right. I think this is our last one. So this is a independent private charity hospital in central Haiti, so out in the rural parts of Haiti where there used to be rice farms. We were asked to engage them. They actually had an x-ray room and they had a portable x-ray machine. Both have been broken for years. So just let that sink in. You got now a 200-bed hospital. They do trauma, they have functioning ORs, and you don't have x-ray capability. So our solution was to get 2 portable machines, one for upstairs, one for downstairs. And it turns out the tech already knew how to run these AMXs, and they had a bioengineer that was familiar with how to work with these. So it's like, wow, this is a super easy project. On this one, we actually get a little bit of data because this private charity hospital already was kind of data-centric about things like how many IV bags, how many antibiotics, how many surgeries. So it's a lot of detail maybe here, but we delivered in March, and they were running up until, let's say, roughly January. So let's call that 4 years, roughly doing 110 x-rays a month for 4 years for $7,700. Doing the math quick in my head, that's just under $2 per x-ray exam. That's our cost. Now, of course, the client may have other expenses like the film. But from my standpoint at my dinner table, I think this was a huge success, and I wish you could get back to Haiti because we need to either repair this machine or get some more equipment to them. That is it on my part. So let me summarize that, and then we'll hand things over to Komlan and Yamile. So we talked briefly about global health, and at least in my experience, it's been a very personal journey, and I've grown in a lot of ways, I hope, from this work. And I think I've found a maybe unique place in the global health landscape where I can make impact. We formed our own organization, which is self-funded, and we practice what we call precision charity. The idea of being very client-focused and very one-on-one focused. We put experienced people into the field so we can get a really precise idea of what's happening and address things correctly, hopefully the first time. And I think when things are done on this one-on-one kind of personal scale, things are very, very fulfilling. Our course, so we focused on capacity development. I think hopefully you guys understand what we mean by capacity development. So it's the full value stream map of building a service, often begins with assessment, often involves donation of equipment and providing education for that. And then the hard part is the long-term engagement to provide parts, support, and maintenance support. And then we went over a couple projects, and I hope you see that we're very high impact, and we're maybe unique in our ability to scale for individual project and provide customization of things. All right, and with that, what I'd like to do is hand things over to Yamile and Komlan. Yamile, maybe I could have you go first. So Yamile Blaine is she's a Haitian radiologist who I first met as a resident in Port-au-Prince. She graduated from their program and then immigrated to the United States, where she repeated her radiology training and is now an attending radiologist at the University of Miami. She's been on a number of mission projects with us. She's an amazing person, and I invite her to give a couple minutes of her thoughts on work in the global health space.
Thank you, Berndt. You're too kind. Yes, so I'm Yamile Blaine. When I first met Berndt and got into contact with hardcore, I was a resident in Haiti. So Haiti, for those of you who don't know, it's a small island in the Caribbean, just a little bit larger than the state of Maryland, let's say. In terms of radiology capacity, it lacks a lot, sadly. I think last I checked the data, it was just below 20 radiologists for a total population of nearly 10 million people. And it's just not human resources that's lacking. It's also equipment in general. And most of these resources, human or otherwise, are centralized. So you're thinking Port-au-Prince, the capital, where sadly is where most of the chaos tend to happen. So as a developing country, Haiti has known its share of donation, humanitarian programs, and you may ask yourself, hardcore is just another one, but we beg to differ. So what makes us different, beside all that Berndt just went through, for my personal experience being both on the, let's say, receiver end of work that hard work did in Haiti as a resident, and then later being an active partner in the group and working in other places like Togo. I think the main thing is philosophy. Donations is a core part of, helping lower income countries getting to a higher level. And there is a difference in approaching donation from a needs-based standpoint versus, leftover basis. There are a lot of equipments that end up in places like Haiti that people cannot use because, they may be missing a single small parts, or they may just not know how to use that specific part of equipment. This is where our precision charity comes into play. And I must say this definitely makes a difference. In the residency in Haiti, donation from hardcore, like ultrasound machine, helped really not only boost the radiology education, because with more machine, it means that more residents could practice at the same time. It also meant that the population that was served in that hospital, which is a public hospital, more patient could get studies done, because you can only do so much. So that's one impact that's very palpable and really easy to pinpoint. The other thing I would say that makes hardcore different is, it may sound cliche, but it's literally the relations that we're able to build with the partners. We know the people we work with, and I want to believe that they do know us. I mean, I was only a resident when I met Berndt, and now I can confidently call him a friend and a colleague. So that is definitely a piece of the work that makes a difference. From being on the other side and helping do work in Togo, applying all of my insights from having worked in a place like Haiti, that's also a developing country. There are a lot of similarities and a lot of things that we can take from one place to another. But also, our ability, I think, to really see each place like a unique environment, as every place is, obviously. I think that also makes the team stronger. So yeah, it's been a real joy and a very fulfilling journey, being part of Hardcore. It's an ever-changing landscape and in global health. As many of you know, the political climate, the global political and security challenges in some of these countries makes the work harder. However, we know and we believe that it's important work and that it's needed work. If we make radiology equipment and radiology education accessible to more parts of the world, people are healthier and it benefits all us. So go hardcore. And if you want to join us, you're welcome.
Awesome. Thank you, Yamile. And then Komlan, hello. So Komlan is a cybersecurity IT specialist. We met because there actually is one ultrasound paper we got published, and for reasons I do not understand, Komlan read that paper and saw that we donated a bunch of equipment in Haiti, and so he reached out to the corresponding author, which is Dr. Hirschman, and said, "Hey, I have some family in Togo. Can you guys help us out?" And this is, I think, right at the beginning of COVID. So Michelle and I had a conversation like, I don't know what to do with this guy. And next thing you know, we had a couple of Zooms, and next thing you know, we became friends. And next thing you know, we have a bunch of projects in Togo. So Komlan is a very humble, wonderful person. So he probably won't say things like what I'm about to say. He is absolutely critical. He's not a clinician, but he's absolutely critical of these projects because he understands the local culture, how to navigate regulatory environment. Which hospital should we work with? Maybe which hospital shouldn't we work with? What might be ethnic considerations? Should we go to dinner with so-and-so or not? Do we invite these other people when we do? I almost do nothing without consulting Komlan, and his guidance has been critical to avoiding landmines and not making fools of ourselves and just getting things done. So sorry, with that obsequious introduction, Komlan, love to hear some of your words.
Good. Thanks, Berndt. I'm Komlan. Like Berndt said, I'm a cybersecurity engineer. I'm located in Houston, Texas, and originally from Togo. And like he said, I happened to stumble on the paper that they wrote, and it started all the adventure. So I want to talk about how this in a foreign country without having a local project manager. Okay. it is one of the situations that you will definitely get into it. It is doable, but it's a little challenging. So what we've learned with hardcore is if you cannot have a local project manager, at least have somebody that is from the place you're trying to impact that lives in the US. So it pretty much gives you two advantages, okay? So you have someone that actually understands the American culture, and then you have someone that understands the culture of the place where you're trying to have an impact with your work, and helps you navigate the process smoothly. Now, the key to success of hardcore is the flexibility that is built in our program, right? So we are not rigid, meaning that it's not a defined agenda that today we have to do this, 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 this. No. As long as we can accomplish the main point, we're good. And that flexibility allows us to do stuff that we couldn't have done before. I can give you an example. Assuming that we've been in a place 2, 3, 4 times, it is wise to start talking to the people in charge of the country. But to get on their schedule, it's usually hard. And once you get on their schedule, being able to actually meet them at the time set is more challenging. So when you have those kind of flexibility, building your program, it allows you to move pieces in the puzzle and move forward. You can now say, okay, the meeting is at 10:30, and then at 8 in the morning, you call saying, okay, no, we can do it at 8:30. Can you come at 9:10? So that flexibility allows you to go to that meeting and then come back and finish your training. Yeah. So when you decide to go in global health, you have to value commitment. And what I mean by that, it's not, I come, I bring you equipment, I train you, and that's it. I expect you to trust me. No. You come, you do it one time, they see you. You come back second time, they see you. You come back the third time, and now they know, okay, this is not a once and done thing. These guys are really committed to what we're doing. And you see a change in the behavior. You are more welcome in the country where you're trying to make your impact. Now, connections, it's very important. Who you know make your project go fast and smooth. You have to get somebody that is well connected, because it is one thing to know the culture, but it's one thing to know who to call when needed. Connection is really, really important in this work. Now, the other thing that I want to talk about is be open to the culture. Be really open to the culture. Whenever you can, try their food, learn their culture. And then at one point, they were making a joke that they were going to give a Togo passport to Dr. Schmit. Why? Because he opened himself to the culture, and then they can see that in him. So those are some of the few advice I wanted to give to the team in case you decide to go into the global health world. And remember that this work has impact. You may not see it, but it does have some impact. When I joined this, I think first, I thought it was for the people, but at the end of the day, I can tell that maybe it's for myself, because the joy that comes every time we do this in the morning and we get home at night, I get home tired. But when we go from Monday to Friday, at the end on Friday, there is this joy in me that I cannot express. Even though I went through all this struggle, we went through all this struggle, at the end of the day, it is for yourself. You feel really, really good about what you have achieved. And on top of that, when we hear report from the field, it encourages you. So the first training that was done to the midwives, I think maybe 3 or 4 weeks later, one of them actually reached out to thank us, saying that we cannot believe what happened, that because of the equipment and the training we gave her, she was able to save a baby's life. How? Because the umbilical cord was around the neck of the baby. And she used the ultrasound to see that, which triggered the process of calling a doctor to come for the delivery. So those are small things, but it's a life that is saved. So definitely I encourage you to, if you can join Hardcore, we're looking for people, and let's change the world together.
Thank you, Komlan. I think maybe now we can entertain any questions if there's questions out there. And
So I'll chime in quickly. And thanks, Berndt and Kamlan and Yali. What a wonderful presentation. There are no questions yet in the chat, but I would encourage everybody to please drop a question in the chat. But Berndt, maybe this is a question for you to start, which is how did you start out? Like how did you start your first like country partnership? I see a lot of amazing themes in terms of relationship, which is of course like really this like key theme that I see across the duration of these projects and this kind of bringing together both equipment with capacity development. So it's not one thing that's separate than another. But there is a question as to how you ended up in these places where you are and have created these really incredible partnerships and longitudinal programs.
yeah, and I invite Komlan and Yamile maybe to comment on this as well. But I think this is a little bit of one of those funny life things where you have an interest, you have an itch, you want to do something, and the path opens. And I think the world is complicated enough, life is complicated enough, you will eventually bump into that person. So if in your mind you're saying, wow, I'm a surgeon and I want to do global health work, you're going to run into somebody. It may be through some religious organization, a school thing, at the tennis club, I don't know. What got me out of the, radiologists aren't useful in the field of low-income countries, let's say, was there was a resident back at UPMC. How he knew I existed, because I was in the community division, I don't even know. But a guy named CJ, he used to work with us. He asked if I'd be the chaperone on this charity mission. It was a real complicated thing. It was a team of there was about 90 other clinical docs going to northern Haiti, and I had no idea what I was going to do as a radiologist. So I'm wandering around with 2 residents in a place where there's no functioning equipment. Like, wow, we're really useless third wheels. But I think that got me out of my chair, so to speak. And once you're in the field, if you have the right intentions, you have right resources, and you want to be helpful, there's just so much need. It's going to happen. So I guess if the question is, what do you do? Well, just set that in your mind as something that you want to do, and it's probably going to unfold. If you want to push it a little bit, I'd say go ahead and find just any organization. So if you're a radiologist, you're often going to be a third wheel, but go with a surgical team. And if you go to throw a dart at a globe, you end up in Paraguay. There's probably a desperate need for radiology in Paraguay, and bring your best heart, and you're going to make friendships, you're going to make relationships. And next thing you know, you're going to run out of money because there's just so much that needs to be done. Let me stop with that, because maybe, Yamile, you've been on both sides of the fence, so to speak, a recipient and now someone who's giving and helping to build capacity, and Komlan, maybe both.
Yeah, I would say there's always things to be done and ways to improve things. If you look at there's different ways to look at it, but if you looking at it from the outside, you may say, "Oh, I'm only just one person. What can I possibly do? How can I possibly make an impact?" But there are other people out there who are willing and who want to do work. So You have to find your team, you have to find your tribe. And once you set your mind to it, once you get to a place, then, you know, it's a matter of figuring out in what way you can best help. Because again, we're not looking for, you know, the biggest impact. We're looking for, you know, what matters to the place where we are, and what can really effectively change things in ways that the locals want.
This is Gail. I want to comment and congratulate you all. It seems you've done some really extraordinary work, and it also seems to me there's great capacity or opportunity, I should say, for scaling radiology work globally. I mean, already in the for-profit world, it's already been scaled up, right? I mean, radiology reports routinely are generating income from around the world. We all know this, and that's been present for a couple decades. So it seems to me that this specialty lends itself better than most to globalization, just because of the nature of it, of imaging being computer based. What I wonder about is that issue of scale. And I think you mentioned, Emily, you know, what can one person do? In neurosurgery, we've kind of turned a corner in the way we think about our core professional responsibilities. And, you know, every physician takes the Hippocratic oath. We've done that for millennia. But we've come to believe that in the last 30 years or so, with globalization, that we've acquired a second core responsibility, and that it's no longer good enough to just take care of the patient in front of you, taking the best possible care of the patient in front of you. If you think that's important, there's kind of a corollary core responsibility in the profession, and that is to support others who are trying to deliver that same good quality care to their patients. And particularly when it doesn't, when technology has improved to the point where you don't even have to leave, not only not your office, you don't even have to leave your home to be helpful. How do you think about scaling up radiology so that more people can do this?
I can take a stab at that. Gail, those are great points, and I think I struggle with this a lot. So there's the ability to scale up the digital moving of images around to have interpretation done, and that's one part of radiology. And I guess we're at the front end of the house, so to speak. So on the capacity development end, you know, we have to be field agents to figure out the equipment issues, donate, implement, and everything we just talked about. So scaling the capacity development part up, I think, is very tricky. I do a lot of reflection about this, and I think part of the secret sauce of what hardcore does is because we're small, we can avoid unintended consequences and dead end projects and find the right kind of partnerships. And so when I think about scaling things up, it's like, okay, it's not that hardcore necessarily gets bigger, it's that we have multiple hardcores. And so, you know, if you joined us or something, you know, you'd become a new team of 15, let's say, and work in some other country doing capacity development. Back to the other part, the interpretive part, sure. I do know one person, he's got, oh gosh, I think 30 radiologists that are on a rotating schedule, and they cover 3 hospitals in Kenya, and they're doing just interpretation. They're not doing capacity development. And I think that gets into a really delicate piece about we as radiologists have a very unique ability to disemploy somebody who's far away. So if I provide a free service, now suddenly somebody else doesn't provide it and they're not getting paid. A little different, you know, for hands-on clinicians, because, you know, if I was a surgeon, I'm going to go home at some point and then I return, you know, the labor and the resources to the local folks. So we have never provided offsite interpretation. I think it's something I'm open to doing as a bridge to independence. So if, you know, they're waiting for radiologists to come, you know, provide the local services for a new, you know, clinical thing that we've developed, I could see doing that. But so far we never have. We've always been able to leave the interpretive part to the locals.
Yeah, and I'm sure that's the goal of all the work that all of us do, is to make it sustainable.
I'm going to jump in. I think that dovetails sort of, it's a little bit different, but dovetails to a question that's in the chat about regulatory issues, which I think was in part is probably related to equipment itself. But I also think that with like even images and kind of, protective things for kind of health and patient protection, I think that these things are kind of interrelated. But I'm curious if you could speak to regulatory issues that you may have encountered and how that's been, how you've kind of navigated those things.
Um, I could take that one, I suppose. I think there's probably several different questions baked into that. So regulation as an FDA approval or CE mark is one piece. So far, we've only worked with approved equipment, either European approved or FDA approved. I think as we step forward with some other organizations doing research things, that's where it gets interesting because now we're talking about IRB. And is it an American IRB to use foreign equipment in a foreign country or a local IRB? That gets maybe interesting as we go forward potentially with academic things. The other regulatory part, this dovetails with a moment ago. So I'm not licensed in, let's say, Togo. I'm not credentialed at Kakaveli Hospital. So we make it very clear we're here as people building capacity. We're not here to do the job or disemploy anybody from their job. That said, occasionally I'm showing an X-ray film and I go, yeah, that looks like tuberculosis or something. Yamla, you want to comment on that part of having been Haitian radiologists? What's it like to have foreign radiologist or foreign somebody in your country?
It's definitely a fine line to walk as you go in people's home and with good intention and try to help. Yes, so most times I think the help that we provide can fall under education. If you assist residents or even attending physician in a different country during their interpretation, I think that's what it is, and the whole idea is to empower them, teach them how to, share the knowledge that you have so that they can take it further. We're not, smarter just because we practice in the US or we have access to more resources. We find that, once you actually give people resources, they usually able to get on with their things. And I think in Haiti, I've been part of other projects outside of hardcore. And I think every time that there was something a little bit deeper, then yes, we would local IRB approval was sought. So I think if in the future in hardcore we decide to do more academic work or research, then that should be the goal. And I don't know if Kamlin has anything to add, but even when doing work in Togo so far, we've always sought the approval of local entities, government when applicable. The idea is not to go in and just act like commandos.
Yeah, that definitely. You want to follow the rules. And remember, most of the doctors there are aware of what's going on in the US and Europe. So all those regulations, they are well aware of what it is. And when you go there, expect them to be asking you questions about those, because that's the norm everywhere. So now, does that mean that a place with no ultrasound is going to reject an ultrasound that is not FDA approved? I cannot opine on that. But again, the best approach is you come with, I'm coming to help you, and I'm coming to help you with an approved equipment. So that's the way to do it.
Awesome. Well, I think we're coming to the top of the hour, and I don't see any further questions in the chat. So I think it's a great opportunity to just say thank you to all of you for your time today, but more importantly, for the work that you are doing over time and continuously, and the thoughtfulness and kind of really intentionality that you're bringing to this space. And so thanks for sharing that with us today. Gail, any other further parting words?
No, I'm just really delighted to have had this opportunity to see more about the great work I've been hearing about for some months now, and would like to welcome those who are watching now and those who will watch it online and on YouTube to join us for our next quarterly webinar, which will be in September on another really interesting global health topic.
So
Great.
thanks, everybody.
Thank you,
Berndt.
everybody.
Thanks for
Thanks
having
so
us.
much to our speakers and all of our organizers and supporters, participants. Thank you.
Thank you.
Take care,
Bye-bye.
everybody.